topic that will, if you like, be one of the core diseases that you need to have a handle on in terms of how you manage patients with this condition. And I'll try and go through both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Those are the two main phenotypic varieties that we classify patients as nowadays. But without further ado, in order to diagnose it, you need to have symptoms that are typical of heart failure. This we'll go into this in more detail a bit later on, but this includes exertional dyspnea, exercise limitation, not always and not always mentioned by patients. They often describe effort limitation as the most common symptom, along with fatigue. So it can be quite specific symptoms at the onset, but later on it becomes more overtly related to dyspnea, orthopnea. That means breathlessness when you're lying down, paroxysmal nocturnal dyspnea, i.e. waking up at night or after a period of recumbency during sleep with acute dyspnea. And then probably the one that is most non-specific, which is swollen legs, which essentially refers to fluid retention, but can be caused by a number of things, including chronic venous disease, any chronic illness that leads to low albumin, chronic renal failure, and so on. So those are the symptoms. We'll go through those in more detail in a minute. The signs typical of heart failure, these would include fourth heart sound, and sometimes it's due to AT. Can you looking at lots of echoes? Can't hear. Can you hear me now? Yes. Okay. Hopefully that's just due to the video stream. Okay. So just to recap, because I'm not sure when people lost audio, there are two phenotypic types of heart failure. One is heart failure with reduced ejection fraction, referred to as HFrEF, and one is heart failure with preserved ejection fraction, referred to as HFpEF. For both, you need symptoms typical of heart failure. I'll go through those in more detail in a minute, but essentially, in the initial stages, this is typically exertional limitation and fatigue more than breathlessness. Later on, you get breathlessness on exertion that's overt. Orthopnea is another symptom. That means when you get breathless lying flat. And importantly, that's a good discriminator between heart failure, dyspnea related to heart failure, as opposed to dyspnea related to chronic lung disease such as COPD. In the former, you get orthopnea. In other words, heart failure is associated with breathlessness lying flat. Whereas with COPD, if anything, breathlessness tends to be either unchanged or is even slightly improved by lying flat, particularly with severe COPD. Paroxysmal nocturnal dyspnea is another symptom of heart failure. That's when you wake up after sleeping, or during sleep rather, with breathlessness, and other signs such as swollen legs related to fluid retention, which is a non-specific sign and can occur with chronic renal failure, any illness that causes hypoalbuminemia, and chronic venous disease, although that can often be unilateral. Signs typical of heart failure include arresting sinus tachycardia, a raised jugular venous pressure, a third or a fourth or a third and a fourth heart sound, crackles in the chest, and pitting edema in the lower limbs. And then the discriminator between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction is a reduction in left ventricular ejection fraction, which is calculated, or at the very least estimated, from an echocardiogram or a similar imaging modality. Now, typically traditionally, reduced ejection fraction would be classed as anyone who had a LVEF of 40% or lower, and preserved ejection fraction would be 50% or higher. And the bit in the middle, 40 to 50%, is a little bit of a grey area, and that's why at the bottom I put this category which has crept in over the last few years, called heart failure with mildly reduced ejection fraction. Formerly, it was described as mid-range ejection fraction, but it's now been renamed as mildly reduced ejection fraction, and that covers the middle ground between 40 and 49%. And it's a grey area because it's a mixed bag of patients. Some patients who are, if you like, have a disease that will eventually lead to heart failure with reduced ejection fraction, and others who've got heart failure with reduced ejection fraction that's improved due to treatment, as well as those patients with heart failure with preserved ejection fraction, whatever the cause or multiple causes of that, that is gradually leading to a reduced ejection fraction. So it's a mixed bag. And in essence, for pragmatic reasons, clinicians tend to treat this mildly reduced ejection fraction as reduced ejection fraction. So all the therapies that relate to heart failure with reduced ejection fraction, for all intents and purposes, for you guys, should be applied to this mildly reduced ejection fraction. But I just wanted to give you a little bit of nuance, because if you read about this in detail, you will come across this term. But in terms of the exam, there'll only be two categories. It'll be HFrEF or HFpEF, and anything below 50% ejection fraction will be considered to be HFrEF. Now, there are additional imaging signs that can sometimes help you, particularly with the category of heart failure and preserved ejection fraction. And this is because sometimes it is quite difficult to disentangle whether someone's symptoms are related to heart failure or not. And if you have an echo that shows left ventricular hypertrophy or left atrial dilatation, or you have moderate to severe diastolic dysfunction on one of various indices that echocardiographers can put in the report, and you have symptoms and signs compatible with heart failure, then that can be classified as heart failure with preserved ejection fraction. So I spent a bit of time on that because sometimes people get muddled. And we can come back to that at the end if that requires further clarification. The next slide gives you a very not overly simplistic, but a simplified way of looking at the etiology of heart failure. One of the difficulties or challenges clinicians managing heart failure have is that heart failure is essentially a phenotypic description and doesn't really tell you very much about the etiology, what's actually caused the disease process. And by separating the potential etiology of either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction into one of these categories, namely diseased myocardium, abnormal loading conditions, or arrhythmia, you can start to hone in on potential etiologies and, of course, potential reversible causes. Obviously, the most common etiology of heart failure in general, whether it's preserved or reduced, is ischemic heart disease, IHD. But other causes of diseased myocardium include toxic causes, for example, certain poisons, and that includes chemotherapeutic agents for cancer, certain chemotherapeutic agents for cancer, immunological causes, myocarditis, infiltrative causes such as amyloidosis or sarcoidosis, genetic causes which lead to idiopathic dilated cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy or hypertrophic cardiomyopathy, and then more rarely metabolic derangements related to a single genotype errors. Following diseased myocardium, the next commonest category are abnormal loading conditions. This is where the heart muscle itself starts out as being essentially normal, but it can't cope with the loading conditions placed on it for various reasons and then starts to fail. Commonest cause of that being hypertension, particularly long-standing hypertension or severe hypertension that's untreated. Then you have severe or significant, that could be moderate valve disease that is present in more than one valve on the left side. We'll come on to that in a minute. So significant valve disease, pericardial disease that's severe, particularly constrictive pericarditis, endocardial conditions which are relatively rare in high-income countries, but you can sometimes see in Africa. High output states, and these relate to large arteriovenous malformations, again, relatively unusual, and then volume overload, which is frequently iatrogenic. So you often see this kind of category in hospitals. And third major category would be arrhythmia, typically tachyarrhythmia, any abnormal heart rhythm that has a rate that's greater than 110 beats per minute and is prolonged can induce this in susceptible individuals. The commonest manifestation of this would be atrial fibrillation that is uncontrolled. But equally, if you have complete heart block or a high-grade AV block, atrioventricular block, and you don't present with a syncope and you are of significant level, will often find that chronic abnormal bradyarrhythmias can manifest with heart failure, a heart failure presentation. So obviously you can have more than one cause, and sometimes there is, if you like, multiple etiologies for heart failure. For example, you could have had a heart attack, that would be a myocardial infarction, and that goes into the diseased myocardium box. And you might have long-standing poorly controlled hypertension, so that would be abnormal loading conditions. But the point about this classification is that it takes you one step beyond just calling things heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, with no effort being made to understand the etiology. And I think from a clinical point of view, it's very important to go through this classification so that at least you can make a clinical diagnosis of what's likely to have been the etiology of the presentation. Going back to the symptoms, I've gone through this already. One sign that I didn't mention was a laterally displaced apex beat. That is a very sensitive sign for chronic heart failure. So always remember that heart failure isn't just patients being breathless. You do need to examine them. You do need to see if they're compatible signs. You need both symptoms and signs and imaging evidence. I think I'm not sure if you can see that. It's probably not very clear. So I will just annotate, if you like, or add my comments verbally. If you're in the community and you have suspected heart failure, essentially, based on clinical grounds, that means you've just got yourself as a clinician and the patient in front of you without any advanced imaging capabilities such as echo or anything beyond that. Then it's a good idea to do a 12-lead ECG and obtain a chest X-ray. If you have a normal chest X-ray and a normal ECG, it's highly unlikely that you have heart failure. Now, obviously, there are lots of borderline ECGs where there's some minor or non-specific abnormalities. So this is referring to a completely normal ECG and a completely normal chest X-ray. And you can often tease out quite a lot of patients who just have a symptom of breathlessness or dyspnea. They're using that. If you have any abnormalities or you're not sure, then the next step would either be to go to echocardiography if you have access to that, or a natriuretic peptide measurement. And there are two types of natriuretic peptides that are commonly used in clinical practice. One is brain natriuretic peptide, BNP, and the other is NT-proBNP, which is essentially a larger fragment of the same BNP molecule. In practical terms, NT-proBNP is much more user-friendly because BNP tends to degrade and give you false results if you have the sample lying around for a while. So if you're in the community and you're transferring the blood sample to a laboratory and you're unsure about the turnaround time, it's often better to use NT-proBNP if you have access to that. And if you have a negative value for either, based on your local normal ranges, then that's very strong evidence that you are not dealing with a patient with heart failure. Conversely, if you have a raised natriuretic peptide measurement, it doesn't always mean that you have heart failure. So you always have to have a confirmatory echocardiogram, no matter what the level of natriuretic peptide is. So I hope that makes some sense. ECG, chest X-ray to, if you like, weed out the patients who have breathlessness alone and you just want to exclude heart failure. People who have more symptoms and you're more concerned, you could do either a natriuretic peptide measurement followed by an echo if the measurement is abnormal, or you can go straight to an echocardiogram if you have access to that. I hope that makes some sense. This slide is really meant to illustrate the clinical paradigm or the clinical time course of heart failure and what tends to happen to health status. It's a chronic disease. It's an archetypal chronic disease in the same way that COPD is, I guess. And what this shows is the course is punctuated by exacerbations, which often result in hospital admissions. And with each exacerbation, just by dint of having an exacerbation, the episode is a little bit like a myocardial infarction. It actually makes future deterioration of heart function more likely. So that's why there's such an emphasis on preventing an exacerbation in the first case and treating each acute exacerbation as aggressively as possible in order to prevent the subsequent deterioration that's associated with it. But nevertheless, typically what can happen without treatment is you have multiple exacerbations that lead to worsening function and deteriorating health status to the point that the patient basically dies. Now, this time course used to be, without treatment, of the same duration as some of the worst cancers that are untreated, such as lung cancer. But with treatment, the actual time span of survival has increased tremendously, and that's a testament to all the researchers, the clinicians, but also the fact that it's much more of a multidisciplinary team effort involving nurse prescribers, heart failure nurses, multiple specialties that can help with comorbidities that impact on heart failure. And so with all of that, this paradigm that I'm showing you here doesn't occur, or at least it's a much more extended time frame. But the idea is to try and prevent the hospital, to diagnose early, but to try and prevent the hospital admissions at all, because each hospital admission is in itself associated with worsening function later on. And as I've mentioned, the medical therapies for heart failure have improved significantly based on multiple randomized clinical trials. And I just put here, this is an early slide, just showing on the vertical axis you have mortality, and I think this is at 3 or 5 years. And you can see that with placebo, the mortality is very high at 60%. And then if you add in an ACE inhibitor based on clinical trials, then you reduce that significantly down to about 40%. If you add in a beta blocker on top of that, obviously this is in patients who can tolerate these drugs, then you reduce it further. Add in a mineralocorticoid receptor antagonist and it reduces further still. So this just gives you an idea of the importance of escalating, or at least starting the main pillars of therapy, which I'll come on to in a minute, and getting those drugs to target as they did in clinical trials to obtain the maximum benefit. So if you could do all this, and in some patients you can't because they don't tolerate the drugs, but if you could, then you can have a massive impact on the prognosis as well as the symptoms of heart failure. Now, the therapy for heart failure is essentially based on 4 pillars currently, and those 4 pillars are a drug to treat the angiotensin system, and that could be either an ACE inhibitor or an AR2B, an angiotensin receptor blocker, or a combination of an angiotensin receptor blocker and a neprilysin inhibitor called Entresto. There's only one brand, if you like, of the drug at the moment. So those are the 3 options you have. The best one of those is probably Entresto. In fact, it is the best clinically. However, in some healthcare organizations or systems, there is, because of the cost of Entresto being quite high, sometimes if patients are doing very well on an ACE inhibitor or an AR2B, then yeah, the slide is small. Let me see if I can increase it. Is that a bit better, maybe? If you can tolerate an ACE inhibitor or an AR2B and your heart failure has improved and you're not symptomatic, then in some healthcare systems they stop at that. But in head-to-head studies between Entresto and optimal ACE inhibitor, I think the one that was tested was lisinopril. Guys, sorry, can I? Sorry. It's kind of just because I'm doing things. Then you can. The Entresto came out on top. Now, the second pillar would be any drug that can affect the sympathetic system. So this will be beta blockers. There are many that have been trialed. The commonest one that's used nowadays is bisoprolol, but you can use carvedilol and metoprolol. Those are the other ones that have been trialed substantially. The next pillar would be a mineralocorticoid receptor antagonist. That's either spironolactone or eplerenone. And then the 4th pillar, which is relatively recent, is an SGLT2 inhibitor. And this is a kind of a relatively exciting development in the last few years because it reduces hospital admissions and morbidity, and also in some cases mortality related to prognosis in terms of heart failure. And importantly, although it was initially tested in diabetic patients because it was originally and is sometimes just used as a diabetic drug, it also works in patients who don't have diabetes. So maybe we can talk about that a bit later if people are interested. Now, if you're still symptomatic despite those therapies, and your left ventricular function hasn't improved, then it's a question of looking at whether there are any reversible causes. And that would include whether the patient has got any symptoms suggestive of ischemic heart disease, in which case they would need to have some form of imaging of the coronary circulation, either a CTCA or an invasive coronary angiogram. Equally, if they have a uncontrolled arrhythmia such as atrial fibrillation, then you'd have to think about whether that A needed to be rate controlled, B whether that needed to be cardioverted in order to treat a tachycardiomyopathy. And then finally, if someone has an ECG that showed a broad QRS complex, then the broader it is, the more likely the patient's going to benefit from device therapy, and that goes by the name of cardiac resynchronization therapy. Now, if your QRS is not broad, and in particular, if you have an ischemic etiology for your heart failure, then sometimes an implantable cardioverter defibrillator is recommended. So these sort of second tier of therapies are very important if symptoms and function has not improved despite the four pillars. Once you've gone beyond that, and once you've excluded reversible causes, then it's a question of deciding whether a patient is likely to be a candidate for advanced heart failure therapies, which includes a left ventricular assist device, or even transplantation, or a left ventricular assist device as a bridge to transplantation. But the majority that would typically be in younger patients who don't have many comorbidities. But typically in older patients, particularly if they're multimorbid, then a symptom-driven or palliative approach is adopted, where you're just giving additional therapies in order to control symptoms, but you're not going to affect prognosis. So this would include adding things like digoxin, hydralazine, trying multiple different types of diuretic, even ultrafiltration if a patient is symptomatic, particularly with fluid overload. Ultimately, patient who doesn't respond to those therapies and continues that decline that I showed you in the earlier slide ends up being managed as end of life, with end of life care. And if they have a device implanted, they often will have that switched off in order to prevent that from being activated at, during the last moments of life. Here is a list of some of the common drugs that are used. You don't have to learn this, and these slides will be available afterwards, so you'll be able to go through them if you so wish. And this drug is Entresto, which has got two components: an AR2B called valsartan, and a neprilysin inhibitor called sacubitril, trade name Entresto. That sometimes comes up in the exam as a MCQ question, so it's worth remembering that. Another thing that's often forgotten, particularly in those who are not responding to therapies, remain symptomatic, elderly, and have multi-morbid features, is their ferritin status, because you can improve symptoms simply by replacing iron. So it's important to always test for ferritin, and if they have ferritin level below 100 micrograms per liter, or if they have a sort of intermediate ferritin level up to about 300, but with a low transferrin saturation, then they're a candidate for high dose intravenous iron therapy, and that has a very quick effect at improving symptoms and exercise capacity. Okay, I think in the interest of time, I'm just going to skip over to heart failure with preserved ejection fraction. Now, this is a bit of a dustbin category. There are multiple causes, and I've got the most common ones listed there, and they often overlap. So often patients will have more than one condition that can contribute. And in terms of prognosis, really there hasn't, it really relates to any of these conditions that may be reversible. Otherwise, you're simply treating symptoms with diuretic therapy. But this part, looking at the potential comorbidities that can lead to a phenotype of heart failure with preserved ejection fraction, are overlooked, and patients just get treated with diuretic therapy alone. One of the commonest comorbidities that can precipitate a crisis, or at least be a major etiological cause of HFpEF, is untreated or poorly treated hypertension, atrial fibrillation. Once again, if you have untreated myocardial ischemia, always worth remembering that patients with recurrent HFpEF always look at whether there's any imaging for significant coronary disease. Then there's these less well-known conditions such as amyloidosis, and obviously COPD and chronic anemia from any cause, obstructive sleep apnea. These are all things that will contribute to a heart failure with preserved ejection fraction phenotype. The actual ultimate pathophysiological cause isn't really well known. It's probably multiple mechanisms, but one common feature is that endothelial dysfunction appears to be quite pronounced, and so a lot of therapies have been directed towards improving that. However, they haven't shown any promise. The only addition to the therapeutic armamentarium in recent times has been the SGLT2 inhibitor class. And if you have a heart failure with preserved ejection fraction phenotype and an ejection fraction below 60%, so 50 to 60%, there seems to be some benefit at that level. But if you have a completely normal ejection fraction, even an SGLT2 inhibitor doesn't seem to make much impact on symptoms. There is also another diuretic, or rather a mineralocorticoid receptor antagonist called spironolactone that some practitioners used based on limited observational data. The only randomized trial that's looked at this TopCat didn't show a benefit from using spironolactone. However, for reasons that I can go into later, there are some practitioners who still use it in addition to diuretic therapy. And this is just a slide, a forest plot, just showing some of the more recent studies. I think there's one that's missed off here, showing that most of the treatments that are used for heart failure with reduced ejection fraction don't seem to have a significant effect when you're treating a patient with heart failure and preserved ejection fraction. My last slide here before questions, because I know we're running out of time, is that heart failure really is a multidisciplinary sport. You do need to have not just a clinician specialist such as a cardiologist, but you do need specialist nurses. You need primary care practitioners involved. Ideally, particularly with multimorbid elderly patients, medicine of old age, clinical pharmacists, general practitioners with a particular interest in the condition, and this all needs to be integrated into both an in-hospital but also strong community service, not least because by preventing the hospital admissions, as I alluded to earlier, the very impact of that is beneficial towards prognosis. And there are various ways of doing this. There are various monitoring systems that, depending on your healthcare system, have been set up. At the most simple level, diuretic lounges are sometimes used And if patients are putting on weight in a rapid fashion, then that can only be due to fluid retention, and you invite them to have outpatient diuresis, trying to prevent a crisis. At the more sophisticated end, there are studies that have shown that if you have an implanted device in the pulmonary trunk or the pulmonary artery, you can measure the impedance of fluid going through, and you can work out whether someone is actually beginning to retain fluid before they actually put on weight. And there is ongoing interest in that. Whether that takes off or not is another matter. But these are all attempts, from the simple to the more complex, to try and identify crises before they occur and intervene, either by escalating therapy or at the very least increasing diuretic therapy to prevent a hospital admission. I think I'm going to stop there because there are lots of other aspects that we can discuss, but that should cover everything in the exam that you're going to be asked potentially. But if there are any more questions, I'm happy to take them now. I think we have about five or 10 minutes. Just put them in the chat box and I will attend to them. What I will also do while people are thinking about questions is I will send over a copy of the heart failure guidelines, but a simplified version that were recently released by the European Society of Cardiology, as well as an aide memoir that comes with that, which could be very useful for revision. What do I need? What do I think about primary care initiation? So yeah, I think the answer to that is yeah. There's no reason why SGLT2 inhibitors can't be initiated in primary care. The only snag is that if someone is diabetic, then you would need to have strong links, and these often occur at primary care level, at least, with diabetic specialist or a diabetic nurse service, so that the management of diabetes is optimized, and also that that the sick day rules are reinforced, and that patients understand to look out for things like increased urinary frequency and any sign of urinary tract infection. Management of heart failure between systolic and diastolic is so I think generally speaking that's sort of old terminology. So the systolic heart failure, I think, refers to heart failure with reduced ejection fraction, and diastolic heart failure is heart failure with preserved ejection fraction. The question about AF, essentially, it's difficult to, if you see a patient in front of you with heart failure and AF for the first time, particularly if the AF is poorly controlled, then you can never know whether that's a result of chronic heart failure or acute on chronic heart failure, or even acute heart failure that's triggered AF acutely, or whether the patient has had chronically poorly treated atrial fibrillation and they happen to be sensitive enough to develop a tachycardiomyopathy. So if you're not sure, then ultimately what happens is the AF gets rate controlled, and if there's a clinical suspicion that it might be a tachycardiomyopathy, then they get put forward for rhythm control management, which often will be cardioversion of some description, either electrical or pharmacological. In many countries, it will be electrical. The other sort of slight nuance here is that if you have patients who have, if you like, newly diagnosed heart failure, particularly if it is quite, you're going from a sort of completely normal heart to a low ejection fraction. I'm thinking here about conditions such as peripartum cardiomyopathy. Then additional therapies become important, such as anticoagulation. So a sudden change in ejection fraction often is associated with the formation of thrombus in the left ventricle, and that obviously can lead to stroke. So particularly if someone has suddenly dropped ejection fraction, then always have to think about anticoagulation. Okay, what's this question? So yeah, I mean the prognosis will really relate to whether all the therapies, the four pillars of therapies such as device therapy have been included, and also comorbidities and ages. There isn't one answer to this, but essentially the prognosis has improved significantly. So there are survivors with quite poor left ventricular function even at 10 years from the onset of diagnosis. But it does depend a lot on the age of the patient. That's the most important determinant, but also whether they've got all the four pillars and additional therapies if they're required. Interestingly, the a large observational audit in I think mainly North American, I think 2 years ago, showed that about 40% of patients who in real world clinical practice who have heart failure with reduced ejection fraction are not on all four pillars. And in fact, in those days, actually, it was only three pillars because SGLT2 inhibitors is only relatively recent. So on all the pillars that they needed to be on, and of those who were on all the relevant classes of drug, only 40% of those were on optimal guideline-directed therapies. In other words, doses. In other words, there is an importance in escalating therapy once you've started the drugs, and a lot of the community efforts in trying to improve heart failure management, particularly for HFrEF, relate to trying to escalate drugs in a way that the patient can tolerate. And there is a lot of work now which is coming to fruition, actually, although the drugs are very expensive, in trying to use agents that can help extend the ability to escalate therapies. One example is an oral calcium resonium binder that can prevent hyperkalemia, which is often one reason why spironolactone and ACE inhibitors or Entresto can't be escalated further, because the potassium starts rising, and obviously hyperkalemia is dangerous. So by adding a resonium binder, you can bind the potassium. It essentially binds in the colon and is passed out in the feces, and you can reduce the systemic level of potassium, and then you can increase the heart failure drugs accordingly. But that's that's at the research end of therapies at the moment, so it's not mainstream. In the community, it's often difficult to start all pillars. Yes, so this is, nobody knows the answer to which one you should start first, or whether you should start them all at the same time. And this is this is an active area of research at the moment, so nobody knows is the short answer. I think it depends a lot on the phenotype of the patient. So if somebody obviously has a resting slow heart rate, then you wouldn't be starting a beta blocker, or at least you wouldn't rush to start a beta blocker until you had all the other therapies on board. Similarly, if someone had really quite bad renal failure, you might start with a beta blocker instead of an ACE inhibitor. So I think it really depends on the phenotype of the patient. And in the guidelines that I'll send to the moderator for those who are interested, there are maybe a dozen different types of phenotype out there, and that will have an effect on which drug you start and which drug you're likely to be able to escalate. So it's more according to the sort of the background of the patient than anything else. But if you had no comorbidities, even in that sort of relatively, if you like, virgin group, it's not clear which ones should be started, particularly if someone comes in acutely, or if someone comes in with an acute exacerbation of previously diagnosed chronic heart failure. So it's an active area of research, and very likely there will be guidelines that help in the next iteration, whenever that is in a few years' time. There are new studies about the use of Entresto and SGLT2. Yes, and essentially, it's the four pillars as I've described them still stand. So you need something for the angiotensin pathway, something for the sympathetic pathway, something for the mineralocorticoid pathway, which is, by the way, not acting as a diuretic at the doses that are used. And you need something for the SGLT2 pathway. Now, no one really knows how the SGLT2 inhibitor works. There's probably multiple reasons. I mean, the simplistic way of looking at it is that it induces glycosuria by preventing absorption of glucose in the proximal convoluted tubule of the nephron. However, that isn't the only mechanism. It does have a vascular remodeling function. It does have a vasodilatory function and has direct effects on the heart itself, as well as obviously metabolic factors such as dysglycemia. So there are multiple mechanisms, and you can certainly use them together. With the new guide, also cover cardiorenal syndrome. Yes, it would. The guidelines, yeah, it will. I think it does cover cardiorenal syndrome, which just basically means renal failure related to heart disease, as opposed to heart failure related to renal disease. So the common paradigm is someone has heart failure with reduced ejection fraction that's progressive, and then they have progressive renal impairment as a result of poor cardiac output. Equally, you can have chronic renal failure that leads to hypertrophy of the left ventricle, that leads to heart failure with preserved ejection fraction. So there are, it works both ways, but the commonest manifestation, I guess, would be cardiorenal syndrome. Is there a target blood pressure pulse when titrating medications? So, yeah, I mean, I think so. For first thing is the patient symptomatic? If they have a symptomatic bradycardia or symptomatic hypertension, then that's obviously too low blood pressure or pulse for that patient. But sort of in the abstract, in the studies, in the randomized controlled trials, they often titrated patients to a blood pressure of about 90 systolic, and most patients can tolerate a pulse of 50. Go below those numbers, and more often than not, you will have symptoms. So those would be the two kind of numbers. I'm not sure I would titrate to those levels, but those would be the, if you like, the limits beyond which you could you could say the patient isn't really tolerating the medication. So symptoms first. Do they get pre-syncopal when they stand up? Are they able to increase their pulse when they try and exert themselves? You can simply measure the pulse and get patients to sit up and down or walk up and down a corridor and see whether the pulse increases even a little bit. And in terms of biochemical target, yeah, I mean, I think the natriuretic peptide is sometimes used. It's not that good at telling you anything other than if it should improve with therapy, but the degree of improvement doesn't really correlate very easily to whether you're going to be readmitted in the near future or whether your prognosis is good or not. But yeah, if you measure natriuretic peptide during therapy, particularly acute therapy, it should come down. Now, the problem there is that if you're using Entresto, that will artificially raise your natriuretic peptide. So it kind of depends on what drugs you're using. So in clinical practice, it's not used that much. It's more used at the diagnostic end of the management spectrum. In other words, is this patient likely to have heart failure, in particular to exclude heart failure? So if you've got a normal natriuretic peptide measurement, then that is a very strong indicator that you're not whatever you're dealing with in terms of patient symptoms, it's not likely to be heart failure. Are there any new drugs to target endothelial dysfunction, not directly. I think there was a lot of interest a year or so ago on pomegranate extract, and I can't remember the various drugs that came from that, but the answer is no, and I think that endothelial dysfunction is usually a catch-all term. It's usually a sort of a final common pathway, and so it's unlikely that there's going to be a magic drug for endothelial dysfunction. But as I say, with it, the one of the concepts here is that we already have a lot of therapies, and a lot of patients are not getting access to these therapies, whether it be drug therapy, whether it be device therapy, whether it be advanced heart failure therapies. And although there will be new drugs that come on the market in time that may target different aspects, we already have many therapies that are underutilized. Remember the audit that I mentioned, the observational study from America, showing that 40% of people were on the pillars, and only 40% of those on all the pillars were at the optimal doses. So there's a lot of work to be done there. There's a lot of work to be done with community services in terms of identifying patients early. There's a lot of work to be done on monitoring patients to try and prevent them from having a crisis, because the natural course of this disease is for crises to occur unless you intervene beforehand. So I think that's the nub of this. There's a lot of therapy available. We need to identify, use it, and also monitor patients in a multidisciplinary framework, because this can't be done just by doctors. But doctors often, well, nearly always will be leading this kind of a service. So it's important that if you are going to be working in primary care predominantly, you can take a lead in this. It's a very common condition, particularly as going back to the earlier slides, the commonest reason for heart failure with reduced ejection fraction is ischemic heart disease. The commonest reason for heart failure with preserved ejection fraction is hypertension. And so those are conditions that are relatively frequently encountered in primary care. And you can have a huge impact. Essentially, it depends on the skill mix that you have in your local healthcare service. If you have access to a specialist in heart failure, obviously that person will be leading or helping lead the service. But in the absence of a specific specialist, then there's no reason why a primary care practitioner with an interest in this cannot organize services accordingly. So one last thing here: once diagnosed with heart failure ejection fraction clarified, is at any point in repeating the echo if symptoms worsen? Yes, in the sense of if someone has a reducing ejection fraction, then they may be eligible for more therapies. Secondly, it depends on the quality of the echo. I mean, the assumption in your question is that the quality of the echo is good. Sometimes the quality isn't so good, and if someone has heart failure with preserved ejection fraction in particular, one worries that you're missing a diagnosis that could be treatable, like amyloidosis, for example, which isn't easy to detect on echo, and it might prompt you maybe not to do a repeat echo, but to do an alternative imaging modality to assess left myocardial function, such as cardiac magnetic resonance imaging. So the answer is yes. If someone deteriorates, it is always worth repeating imaging. It will commonly be echo, but not just echo. Okay, I think 3 minutes, or maybe not. I don't know what the moderator will cut me off soon, probably. But I think if there are any additional questions, then please pass them on to the moderator. I will, I'll pass on the guidelines so that they can be shared. Importantly for the exam, remember this educational piece has 2 levels. One is to, if you like, help you get through the exam as part of a wider impetus to get your diploma, but the second is to actually stimulate you and help your clinical practice. So for the exam, the questions will be straightforward, but they will touch on core topics, and this is one of them. But I've given you much more than you probably need, but hopefully the additional information will be useful for your clinical practice. Okay, I think I'm going to sign off before my computer does something I don't want it to do. I have been fighting with it all week. So thank you very much for your attention, and see you soon. Bye bye.